Hi everyone, this is Mr Neel Raithatha, also known as the Wax Whisperer. Thank you for joining me in my latest video. This is of a patient who attended with bilateral, fully occluding soft earwax, and we're just commencing in the patient's left ear. Now, this is a humongous amount of earwax. Because of the consistency, a lot of the earwax got vacuumed up, so I'm not able to show you large plugs. But if this were to come out in big, large pieces and lumps, and I was able to both measure and weigh it, I would suspect that it wouldn't be far off one of the heaviest and the largest earwax removal I've performed. So because of the consistency of this earwax, just putting some olive oil earwax spray in there, and if you've been watching my videos for a while, you know that I use the drops almost as a binding agent. So again, I'm going to use one of my cooking food analogies. If you're making, for example, a potato cake or a fish cake, to bind all the ingredients, you'd use an egg. And similarly, I use olive oil in the ear to help bind the wax together, so we can try and get it out in larger lumps. Otherwise, it's too wet, too loose. It breaks up into little pieces. You can see it's very good. This is more of a deeper layer now because the oil hasn't penetrated this, but it's very glutinous and sticky. And it doesn't really vacuum very well, and it can clog up the inside of the suction probe. So I'm just working around the edge, and the way we remove this type of wax is just do it in layers. Now, this patient, although the ear canal is quite wide, you can see the zone of suction probe comfortably fits inside the patient's ear canal. It is very bendy, however, so the second bend, and as I remove this wax and near to the end of the procedure in their left ear, when I'm removing some wax off near the eardrum, you'll see, you may be able to see better how bendy this ear canal is. So I'm just you can probably see from here as well. So this is just at the entrance of the ear canal. This is a little pit at the entrance, and I'm going to have to go to the right and back to the left. So it is quite a pronounced second bend that they've got. And you can see this wax plug is enveloped by dead skin. Now, this skin was originally on the ear canal itself, but it's died and it's shedded, but it hasn't come out of the ear. Instead, it's enveloped itself around the plug of the wax, keeping it in place, which makes it a bit more difficult to remove because we've got to try and detach the skin from the canal as well. So you can see we're making good progress. Now, the average ear canal is between 2.4 and 3 centimetres, so an average around 2.6, 2.7. And for this patient, this earwax, this occluding earwax, fill the entire ear canal, so right from the entrance to their eardrum. So it was a significant blockage. They weren't able, interestingly, to hear the suction machine, our suction machine. And the suction machine, I'm just going to go to the suction machine and put it on now. I'm going to place, I'm actually editing this video on my phone, so I'm putting the phone where the patient would sit normally. And I'm hoping you can hear that. So that much suction machine. And now that's not, that's the machine itself. Obviously, then you've got the machine is attached to the suction tubing, to which the zone of suction probe, which you can see in the ear, is attached to. So they could hear the suction within the ear as I was clearing the wax, but they struggle to actually hear the machine, which is an external noise. And I would probably equate the noise of a suction machine, I'm just trying to give you an everyday example, probably just below a hairdryer. That's obviously not beside your ear, but if you've got a hairdryer and you've got it on and you just hold it almost at half an arm's length away from you, it's to that level. So you can imagine just how hard of hearing they were with all this wax. Now, we can see the eardrum there in the distance. Already their symptoms are completely alleviated. Now, I'm just trying to get as much of this sticky, soft wax. Now, when it's sticky like this, we're on the bony part of the ear canal, so we've got to be really gentle. I don't want to be making contact with the patient's bony part of the ear canal, especially because the patient can hear now. So, and it's this part that's a bit tricky because this is to the front part of the ear canal and the bend to the ear canal is just to the left. So the second bend, maybe when I go back out and come back in, you'll be able to see that second bend. So it's difficult to access the anterior part of the ear canal, which is to the left, when they've got such a pronounced bend. So, and that's because I have to get the endoscope right to the right hand side of the ear canal to make space for the suction probe. So I'm just hovering up near the entrance, all this oil that we've used, and again it's not going to affect the hearing, but we want the cartilaginous portion here, so we can put a bit more pressure here. But still, I'm just trying to hover over. I'm just using the fine end suction probe now. So what I'm trying to do, I'm just trying to stretch the ear open. I'm trying to get the endoscope to the right hand side of the ear as much as possible, which then allows me access. I've got a bit more of a better angle here with the suction probe. You can see it's a lot more steadier. It's just because we've just repositioned now. I'm not going to try and get any more off the anterior canal wall there. It's not going to cause the patient any problems whatsoever, and we just risk unnecessarily grazing the ear canal, cutting it, bruising it, which is then going to cause the patient injury, trauma, possibly infection, and they're not going to be happy. So again, I'm just hovering over this. If it comes away, excellent. If not, you can see it's not really wanting to come away. I think I've just left it that. So that's the patient's left ear done, and they could hear so much better. Now, interestingly, the suction machine was actually to the patient's right hand side, and this is their right ear, so they couldn't still hear it at this stage in their right ear, but they could in their left. So just immediately, I've just put some olive oil spray in here. Because we're near the entrance, it can get a bit blurry slightly, just momentarily, because you got the hairs there as well. And I'm actually suctioning whilst the oil is in situ. So the suction probe is not only vacuuming the wax, it's also vacuuming the oil, and as it's vacuuming the oil, you can get a bit blurry because the oil's getting vacuumed up, and obviously light travels not as well through oil as it does through natural air. So I'm just trying to bring this, again it's very sticky and wet and glutinous, I'm just trying to slowly detach this from the canal wall. They have got a layer of dead skin once more, just enveloping the plug. You can just see that skin there, the texture, the ribbon effect it has, the glossy appearance. So probably in the mid portion of the canal now, and on the back part now, this is the bottom part. I'm just trying to tease the skin away, and you can see that skin now. We've done a good job at detaching that from the canal wall, at least from the bottom half of the ear. And the key is here, if we poke and prod the suction probe into the wax too much, it will just block the suction probe and it will just indent the wax. We just got to be careful of how much pressure we apply. We're just going to almost kiss the surface and just gently just trying to wriggle this away. And we've gone all the way around the perimeter, and we're just trying to, and we've mobilized this plug now. Now it's just a case of bringing it forwards. But again, if I embed the suction probe too much into the wax, because it's really soft, it's just going to block. So it's fully mobilized now, and you can see that some of that skin just blocked the suction probe. Just going from the roof and just trying to bring it down. So we're right near the entrance now. It's lodged at the entrance. So the endoscope at the moment, it's not even in the ear, it's just held on the outside portion of the ear. I'm just trying to wriggle this through. So that cartilage to the right is actually the tragus, that's the external cartilage. Okay, it's just got a bit blurry just because of all the oil. There we are, just got that plug out. just going to have a look back in. So this ear is a bit narrower. The canal, so generally speaking, the canal's wide and it's bendy just like the patient's left ear. But towards the eardrum, there's a bit more of a narrowing of the canal as opposed to when you're making a comparison to their left ear. Now I'm going to come back for this in a moment, I think, with a Jobson horn, just to scoop up some of this soft sticky wax. Yeah, just trying to, I think I was just almost standing up so I can look down into the ear at this stage. It's a nice healthy eardrum. Again, you've got some staining there. That's residual wax. I'm just going to hover over it. If it comes away, brilliant. If not, I'm just going to leave that there. This is natural, healthy wax. And it's not coming away easy, in lumps, so just leaving that there. We're not going to risk causing any injury or trauma to the patient. Just using a Jobson horn now, because we're on the cartilaginous portion here. So the second bend is just to the cartilage, to the just beyond this Jobson horn. You can see the ear canal, it curves from right to left and then backs in a straight line, and that borders where the bone meets the cartilaginous portion. So here we know we're on the cartilaginous portion, we can put a bit of pressure. It's not going to be uncomfortable for the patient. But just here to the right, that's where the bony part starts. Well, I hope you enjoyed that video, guys, and you're all keeping well and safe. Do stay tuned. I've got loads more videos to upload during the course of the week. Take care, speak soon.